Good afternoon.
Good afternoon, madam.
I'm teaching from the ward today because of the power cuts. Are you able to hear me clearly?
Yes, madam.
No problem?
No, madam.
Fine, okay. So, this is not how I usually teach. If you can't hear me or there's any problem with the signal, please either interrupt me or put it in the chat, okay?
Okay, madam.
Right, thanks. Let's get started. Okay. So, the topic that I'm going to discuss with you first is the anxiety disorders. Now, the material that we need to cover today are the 5 anxiety disorders and OCD, which is obsessive compulsive disorder. Slides of this lecture have already been uploaded to the LMS, and I hope you're able to access those and to listen to those at your leisure. However, I would like to take you on an overview of this topic using approximately 45 minutes and leaving the last 15 minutes for you to ask questions. As I mentioned before, this is my first time teaching in the ward and using a mobile hotspot for internet. So please bear with me if there are any shortcomings. I have done this because of the power outages which are currently going on. Please feel free to let me know if there was any point at which you were not able to hear clearly or you were not able to join or anything like that. And I would be happy to either repeat this or whatever is required. Right, so that's the preliminaries. The second thing I want you to know is that I tend to always want to start Zoom classes bang on the minute, right? Because I don't think that we should be held up by traffic or queuing when we need to join on Zoom. However, as I was in the ward, I was called out for some assistance, which is why I myself was late today. But let's try to keep that to a minimum in the future. Okay, so I would encourage you to join maybe 1, maybe 2 minutes early for my classes. Now, of the anxiety disorders and obsessive compulsive disorder, anxiety disorders are the easier ones to understand. And that's what I'm going to teach you first. What is anxiety? Anxiety is a mood like happiness, sadness, anger, and fear or anxiety. They're all mood states. And in psychiatry, we also use the word affect. A-F-F-E-C-T, affect. So anxiety is a mood or affective state. And simply put, it is probably a state of unease, a sense of discomfort that something unpleasant is anticipated. We've all experienced the mood anxiety. Which takes us to the question, what then is an anxiety disorder? An anxiety disorder is when the anxiety is at an intensity or of a duration which is abnormal. So either the anxiety is so intense that it's abnormal, or it's so prolonged and pervasive and persistent as to be abnormal. And of course, usually, as you will begin to see as you progress through this module, in psychiatry, we are often dealing with things which normal people and persons with a disorder experience. You know, we all get irritable sometimes. We are all happy sometimes. We're all afraid. We're all scared sometimes. When does it become a disorder? So it becomes a disorder. Usually we say something meets the threshold for the diagnosis of a disorder when it reaches the level to cause disability or disruption to functioning of the person, right? It's a disorder when it's causing disability or disruption of functioning or significant distress. It's a disorder when it disrupts function or causes significant distress. That is usually when we say something has reached the threshold for a disorder. So the anxiety disorders are characterized by either very intense or very persistently prolonged anxiety. And they're disorders because they are causing a disruption of functioning or significant distress. All of this material and more is within the pre-recorded slides. So I'm hoping that I'm just able to take you we're almost having a, well, not a conversation, I suppose, a one-sided conversation, but a monologue perhaps, but that I'm able to walk you down the pathway of understanding these in the context of an overview, where you can then fit in the lesser details once you have understood the terrain that you need to get through. As I said before, please feel free to post any questions which are relevant to the topic or at least to the module, and I will do my best to get to them. Now, this is something which is in fact true. This is something which is in fact true of all disorders. Okay? All mood states. Rather, all moods or all affects, not only anxiety, right? Whether it is elation, depression, irritability, or anxiety, there's always the emotional component, the mood, the emotion, okay? We tend to use the words mood and affect interchangeably. So there is the emotion, the felt experience, right? There is cognition. So, for example, in anxiety, there is the emotion, the felt state of unease. There are cognitions, which are thoughts. I feel something bad is going to happen. I feel something terrible is going to happen. I'm worried about my safety. Those are the cognitions of anxiety. Then, moving down, there are physical. In psychiatry, we tend to use the slightly old-fashioned word somatic. Somatic is used synonymously with the word physical. Anywhere you hear the word somatic, you can replace it with the word physical. But there are somatic or physical manifestations of anxiety, and those could be the sense of trembling, the sense of sweating, the sense of having cold, clammy extremities. It could be a sense of choking. It could be a sense of tightness in the chest. It could be palpitations, rapid breathing. These are all physical or somatic manifestations of anxiety. And then there are the accompanying behaviors, right? So a tendency to engage in either fight or flight. Some people might add to that freeze. There is fight, there is flight, and there is freeze. Okay, so as I was saying before, all affect states have an emotion, a cognition, a physical, and a behavioral component, if you think about them. If you take elation or significant happiness, there is a felt, emotional, affective state. There are cognitions that go with being very happy. There are physical manifestations, not perhaps very pronounced, but there are some physical manifestations, at least, of being happy. And there are behaviors associated with being happy. The same applies to anger or irritability. There is the emotion, the affect, the felt emotion. There are cognitions associated with anger, irritability. There are physical manifestations of muscle tension, for example, tachycardia, palpitations. And there are behaviors, again, associated with anger or irritability. So all moods have this, right? And anxiety is no exception. This is what I was speaking about with you a moment ago. So the emotion, anxious people can demonstrate the typical anxiety or sense of fearfulness. Some people become a little bit irritable when they're anxious, and which is why I have popped that on there in the top left. The behaviors are typically of restlessness and avoidance. There's cognitions and there are physical manifestations. But let's move on from this. Don't get bogged down in the detail. We're trying to understand, and then everything will be very, very clear, because what makes anxiety disorders easy to understand is anxiety is an experience we all have, unlike, say, psychosis, right? So in a sense, these are quite easy. And there are 5 anxiety disorders which we will get through this afternoon. These here on the screen are the 5. And this is usually the order in which I teach them. Now, these 5 disorders, moving back a slide, these 5 disorders are of 2 broad groups. The group on your left, I don't know if you can see my cursor, but the group on your left are all disorders which are triggered by particular situations or objects. So there's an identifiable trigger for the 3 on the left. Whether it is a specific phobia, whether it is a specific phobia to do with snakes or spiders, or as is all too common in our country with cockroaches, specific phobia, or social phobia, particular social situations trigger it. That person is not going to be developing anxiety everywhere, but only in social situations. Agoraphobia, fear of the marketplace, fear of open spaces, fear of places you can't escape. We'll come to all of that. Very interesting material. We'll come to all of that. But what I want you to remember is that the 3 disorders on your left are associated with specific triggers. The person with that disorder only develops anxiety when exposed to that particular trigger. Whereas the disorders on the right, in contrast, can occur at any time. The person with generalized anxiety can have anxiety at any time. The person with panic disorder can experience a panic attack at any time. And I hope this is clear, and I hope that you will pop it into the chat if it is not. Generalized anxiety disorder is simply a disorder, as its name suggests, in which the person is experiencing high levels of free-floating anxiety. It is at the level or threshold of a disorder because it causes significant distress and disrupts functioning. But it is free-floating. It involves 2 or more areas of a person's life. There are multiple areas of that person's life which are affected because it is generalized, as its name suggests, and it's typically there for a long time. These are differential diagnoses. And for those of you who take the time and effort to access the slides on LMS, you will find that I have included material on differential diagnoses and treatment, because while those are not assessed in the mental health module, I know through my own bitter experience that it is vastly easier to have some overview of the actual clinical aspects, such as differential diagnoses and management, even at this early stage, so that you are better equipped to face your finals, to approach your professorials with that material in hand. You do not need to learn about the management now. You do not need to learn the clinical aspects now. But I have taken the time and trouble to include those in these recorded lectures because I know that there is a vast amount of material. There are 5 anxiety disorders as well as OCD, which will be covered in 1 hour here and possibly in 1 class in your professorials. And unless I provide you with some material at some point, you are going to struggle. You're going to be reading for yourself, which is why it's there. If you're not interested, leave it alone. If you want to have a look at it and know that it is there for you in due course when you arrive for your professorials. So this is why that is there. I need really make no further apology for its presence. These are typical differential diagnoses of generalized anxiety. Perhaps these will not make sense to you now in your first or second week of the mental health module. But we need to decide as doctors, as clinicians, whether we are treating generalized anxiety disorder or somebody who simply has a lifetime of being an anxious person. Is it simply an anxious personality that this person has? Or is it generalized anxiety disorder? Is this just anxiety on its own, or is it part of something else? I'm not going into any further detail here. I'm just mentioning these 3 for you to realize that these disorders, which you will potentially come across in rheumatology, clinical medicine, gastroenterology, and so on, involve a lot, are formulated, are considered to be potentially physical or somatic manifestations of anxiety, which is another way of looking at these disorders. Okay? But again, that is not relevant to the discussion at hand. How would you treat generalized anxiety? Well, it's very easy. I'm sorry the slides are skipping back and forth. That is because these were recorded slides and the timings have not got fully deleted from the slides. Treatment includes patient education, guided self-help, helping them with applied relaxation, and in and where necessary, GABAergics and serotonergic drugs. You may or may not have already had these lectures, and your GABAergics are benzodiazepines. Your serotonergics are usually your selective serotonin reuptake inhibitors, and more occasionally, the dual reuptake inhibitors. I've just finished telling you about generalized anxiety disorder. Free-floating anxiety, 2 or more aspects of a person's life will always be affected. So if I'm only worrying about my exams, that's not generalized anxiety. And it's at the threshold for a disorder, it's generalized, and usually it's been there for a while, for 6 months or more. I'm not going to diagnose generalized anxiety disorder in somebody who's extremely anxious for a week. And there's various differential diagnoses. Is this in fact generalized anxiety? Is this simply how this person has been their entire lives? Is that simply personality? Easy one for you to remember, and a few other clinical diagnoses. You educate your patient, you will guide them towards self-help, relaxation, potentially coping better with trivial stressors. Where necessary, we may use medications, typically GABAergics, which are your benzodiazepines, and serotonergics, which are your SSRIs, and more rarely your SNRIs. Now, why I've talked about this here is this is pretty much the model that all the anxiety disorder treatments take. And you will see that in a minute. If you can just take a step back, once we talk about the 5 disorders, you will see that there's a lot that they have in common. Which brings us to panic. What is a panic attack? What do you think a panic attack is? To me, a panic attack is short, sharp, sudden, and severe anxiety. Short, sharp, sudden, severe anxiety. It's literally like a lightning bolt. And it is called a disorder when it causes distress and disruption of functioning. So panic attacks, recurrent panic attacks characterize panic disorder. People tend to have anticipatory anxiety. In other words, they're constantly anticipating another attack. And sometimes they become avoidant. In other words, panic disorder, I said, is not situation specific. There's no specific trigger. It's not that they only have a panic attack every time they see a snake or a reptile. It's not that they have a panic attack every time they see a spider. These are people who have sudden panic attacks. There's no identifiable trigger. However, sometimes these people begin to anticipate these things and they become avoidant. What then do they avoid? They avoid things that they think might bring it on or might be signaling the early part of a attack. For example, last week, I met a patient with panic disorder whose panic attacks start with, I met a patient with panic disorder whose panic attacks start with palpitations. Now, he has stopped walking briskly or exercising at all because he is afraid that walking briskly or exercising will cause his heart rate to increase and for him to feel palpitations, and that he feels might trigger it. So sometimes they develop avoidance of certain things. So panic disorder is recurrent panic attacks. How will we treat it? Can I just take a moment to say that a panic attack, which is your short, sharp, sudden, severe anxiety, will have not only the emotion, the felt effect, but also cognitions. I'm going to die, something terrible is happening to me. We'll also have somatic or physical symptoms: heart racing, rapid breathing, tightness in the chest, tightness in the throat, dry mouth, trembling, clammy exteriors, sweating, perhaps even a certain amount of dizziness. Perhaps with the tachypnea, with the rapid breathing or the hyperventilation, perhaps tingling and numbness in the peripheries as well. So panic attacks again have an emotion and affect. They again have physical symptoms. They again have particular cognitions and sometimes behaviors such as, demanding to be rushed to hospital or something like that. Okay. So that just exemplifies what I told you earlier. How would I treat panic disorder? Well, patient education, medication. The medication again would be GABAergic, which are benzodiazepines, and serotonergics, which are your SSRIs. There is CBT for just about everything. And the CBT here is primarily cognitive for panic. It focuses a lot on the cognitions. There's a little bit of behavioral work to do as well. And we teach them relaxation techniques to bring their anxiety levels down. Now, to fit this material into 60 minutes or less, I have to go at about this speed. If you are unable to understand, pop it in the chat and I will get to it. Specific phobia, incredibly easy. Fear of something specific: spiders, cockroaches, snakes, more rarely dogs, cats, butterflies. blood, needles, fear of flying. They're all specific phobias. These people tend to avoid these situations and to develop a horrendous amount of anticipatory anxiety. And we would treat these with a particular form of therapy, which is known as graded exposure, which is that if somebody has a fear of cockroaches, you would list out situations which would cause fear. Thinking of a cockroach, seeing an image of a cockroach across a room, seeing a color image of a cockroach up close, seeing a video clip of a cockroach, seeing a cockroach in a jam bottle, being in a room at the other end of a room with a cockroach, being able to approach a cockroach. Perhaps I can't do it, but perhaps even handling a cockroach. So what you do is you grade these situations in order of the level of anxiety the person describes experiencing. So you, together with your patient or your client, you grade the situations in order of the amount of anxiety they would cause, and you expose in a graded manner, graded exposure. Right, now this takes us to another disorder. Social phobia. Now, social phobia is a disorder. Social phobia is when people are afraid of being observed and negatively evaluated. They're afraid of being criticized by other people. They're afraid of other people thinking badly of them. So it's a fear of being observed. It's a fear of being negatively evaluated. If unclear, please ask me. Okay? So social phobia is typically seen in situations where we may be observed doing something in front of other people. Some people are afraid of speaking because they feel other people will be observing and criticizing or laughing at the way they speak. Some people are afraid of eating in restaurants, in canteens, at weddings, because they're afraid that people will observe, evaluate, and criticize the way they eat, that they don't eat nicely or they're sloppy or something like that. Some people have difficulty writing, signing forms in banks, in offices. So writing, eating, speaking, very, very common. But even more commonly, performance situations, having to sing, having to dance, having to make a speech, having to recite a poem, having to deliver a lecture, having to do any of these things, these performance situations can trigger anxiety. So for this reason, we talk about anxiety, which can be generalized in all situations or only in specific performance situations only. So some people have anxiety in all these situations. Some people have it only in relation to performance, and they simply cannot face it. It disrupts their functioning, it causes distress, but they simply cannot face that particular performance, which is essential. Maybe performance which they have to do, maybe making a presentation which they have to do, maybe whatever it is. So some people have social phobia, which is very in specified performance situations only. Some people have social phobia, which is generalized to many situations, as I mentioned before. And to those of us who feel a little bit anxious before making a presentation, who would rather not do it, I'll remind you that unless it's disrupting your functioning or causing significant distress, it's not at the threshold for the diagnosis of a disorder, okay? These are differential diagnoses. These are differential diagnoses to be considered, which you will understand once you've done more of the module. Okay, agoraphobia is similar. People with schizophrenia are afraid of being around other people because they feel afraid that something nasty is going to be happening to them. Okay, that's quite different. And of course, there's normal shyness. All in good time, we can come back to these. And you need to be aware that social phobia is a very common anxiety disorder. And some people have actually lived with these things for many, many years before they come for treatment. Say in contrast to panic disorder, nobody with panic disorder is going to be away from services for very long. They might go to the OPD, the neurologist, or the cardiologist rather than the psychiatrist, but they will come for treatment with panic disorder. They're not going to stay at home. Social phobia is not like that. People can have social phobia for a very long time and not seek help. Instead, they may have been medicating themselves with things like alcohol in social situations. Some people become depressed, and social phobia is often comorbid with the other anxiety disorders. And we believe it is an interplay between genetics, conditioning, and cognition, which is probably more than you would understand just now. People have lots of erroneous thinking. This is only extra material, which is nice to know. You don't need to know this really. But there's lots of cognitions associated with social phobia. Why one person might have it and another person doesn't. The person with social phobia has too high standards, excessively high standards. They have a lot of negative beliefs about their own abilities. They, while in social situations, they're scrutinizing themselves rather than focusing on what's going on. They're scrutinizing themselves. Am I doing something wrong? Am I doing something wrong? And they are almost seeing themselves with all
Yes, madam.
you can. Okay. I don't know when exactly I lost you. Did you see this slide? Did you see this slide before?
Yes, madam.
Okay, thank you. All right, so I'm just moving through this. So I was saying in social phobia that people tend to have had these for an incredibly long time, and therefore they have sometimes been medicating themselves with alcohol, and with time they can develop alcohol use disorders, harmful use, dependence. So those become comorbidities. Some people with social phobia, I said they think very negatively about themselves, with time can develop depression, major depressive disorder, clinical depression. Sometimes there are other anxiety disorders which are comorbid. Okay, right. So it's a very common anxiety disorder. It's the second commonest. What do you think the commonest anxiety disorder is? Which one of the 5 would you pick as the commonest anxiety disorder? Anyone? What do you think it is?
Specific phobia?
Yes, I would agree. Well done. Right. So moving on. Okay, so this was just to say that it's multifactorial. We're still repeating the same slides. You know, something that you can trip out every time somebody asks you the management for a great variety of number of disorders in psychiatry, except perhaps bipolar affective disorder and schizophrenia. Certainly, for all the anxiety disorders and OCD, for the entirety of the 6 disorders of this lecture, something you can trip out at any point somebody asks you what the management is CBT, cognitive behavior therapy, CBT, which involves cognitive behavioral therapy. And here, with regard to social phobia, there's cognitive work to be done regarding those negative evaluations and high standards and all of that. There is self-exposure. There is a graded self-exposure to various feared situations. And in certain instances, we help them with feedback. But as not every person is suitable for non-pharmacological or psychological therapies, we do sometimes use pharmacological therapy. Not everybody can manage with talk therapies. You need a therapist who is trained, experienced, and has enough time. You need a patient who can come to therapy sessions every week for a couple of weeks, anticipating to spend 50 minutes to an hour in therapy each week. So you need the therapist and the client to have that amount of time. You need an experienced therapist. You need a psychologically minded patient who has the ability to describe how they're feeling, what they're thinking. Somebody who's in touch with their thoughts and their emotions and can express them verbally. Somebody who is motivated. So that isn't always the case, but for the patient who can't or won't engage with therapy, we can and we do use pharmacological therapies. Okay? We can and we do use pharmacological therapies. Although they would take a long time. Now, this is the last anxiety disorder which we have to discuss, agoraphobia. The word agoraphobia means fear of the marketplace. The word agoraphobia is fear of the marketplace. What agoraphobia actually is in fact a fear of being away from home. And especially this thing in the middle of your pyramid, which is a fear of situations which cannot easily be left. Fear of being away from home, but particularly fear of situations which cannot easily be left. A fear of being in the middle of a crowd, a fear of being in the middle of a bus, of a railway carriage. They're more comfortable by the entrance or the exit. They're not comfortable being in the middle. They're not comfortable being surrounded by people. They're not comfortable in the middle of a movie theater or a lecture theater. So they tend to become very isolated. It's a very, very isolating disorder. And it's one of the rarest disorders for us as clinicians to see, because getting these people to therapy can be incredibly difficult. There's various diagnostic criteria and conventions, perhaps beyond the level of and remit of the module. Again, there are important differential diagnoses. Panic disorders. So you can have agoraphobia, or you can have panic disorder, or you can have social phobia, or the person may simply be staying indoors because they are in some sort of paranoid state, because they have persecutory delusions, for example. So those are common differential diagnoses. And ladies and gentlemen, that's the end of the anxiety disorders. Let me just very quickly hope that the internet is playing fair, and I will quickly show you the slides on OCD. If you have any questions, please pop them in the chat now.